In this video, I will show you examples of using theories of clinical reasoning in practice. An important aspect of clinical reasoning are semantic qualifiers. A patient or a student who isn't able to use semantic qualifiers may say it is getting stronger and stronger instead of it is progressive, it started rapidly instead of acute onset, or when I touch the abdomen it is soft when they mean soft in palpation. Using semantic qualifiers leads to better clinical reasoning, so how can we integrate them into our teaching? Firstly, we can pay careful attention to what students are referring to us. Also, we can ask them to write down the history that they have taken from the patient in bedside classes and ask other students to read and correct this history, trying to find semantic qualifiers or to find words that could be replaced by semantic qualifiers. How can we use knowledge encapsulation in teaching? For the bedside, we can compare and contrast different clinical situations with students based on the example of the patient that we are presenting them or that they have already examined. For example, how would it be different in blood results if it was a viral and not a bacterial infection? Or how would it affect your diagnosis if the rheumatoid factor was negative? In seminar, we can try to get this description from students' heads or try to create them together during the class. Please define for me how a patient with acute laryngitis would present. How would it be different from a patient in the same age with acute asthma exacerbation or bronchiolitis? Now we come to the illness scripts in dual process theory. They are built with the experience and number of patients that we meet during medical career. If we are able to show to our students the analytical way of solving each case, they can build their own illness scripts. With virtual and clinical experience and new encounters, we can also assess our scripts and update them. Firstly, we have a case study during seminar. Afterwards, the students work with virtual patient cases. Then, already solved cases are being analyzed to prepare for real patient encounters. In all these steps, the illness scripts can be assessed and updated. How can we use motivation and emotion to improve the clinical reasoning teaching process? Firstly, we can provide appropriate support. Furthermore, we can give a safe environment to make mistakes. We can also encourage learners to commit to diagnosis and therapy. Remember that the aim has to be SMART, meaning specific, measurable, achievable, realistic, and time-bound. This maintains the motivation on a high level. Examples would be to vote with students on diagnosis or treatment, asking them to work in groups, propose treatment options, and prepare them to talk with patients about them. Every example that triggers their emotions or shows them the importance of what they are doing will be adequate to use while teaching. Now we come to the last aspect of the video, situativity. Situativity is conditioned by the environment, equipment, patient perspective, self-comfort of each student, and emotions. Possible methods of teaching clinical reasoning where a lot of stress is put on a situative context are, for example, role-playing, because it allows a change of perspective. Also, interprofessional classes with discussion and different aspects can be helpful. You can also integrate high-fidelity simulations to get the practice as close to the real life as possible. Thank you for watching the video, and hopefully it makes it easier for you to implement theories of clinical reasoning into practice.